This is Module 5, Justification, Principles. Please take time to read through the learning outcomes for this module. In terms of knowledge and understanding, we hope that at the conclusion of the module, you will have gained an understanding of the principles underlying justification, including the ICRP and European frameworks. We also hope that you will have a knowledge of the special situations related to justification, for example, medico-legal and screening issues. This is a very theoretical module, so we don't anticipate that you will have acquired skills or practical abilities, but we do hope that you will have a judgment and a stance of being able to exercise appropriate judgment in determining the appropriateness of X-ray examinations of patients. Let's start by looking at some background. The United Nations Scientific Committee on the Effects of Atomic Radiation produced their report for the General Assembly in 2008, and this was very recently published in 2010. They give us some interesting information about the use of radiology worldwide over a period of time. In 1988, Unskier estimated that the number of examinations performed worldwide was 1,380 million, an enormous number of X-ray examinations when we look at it on a worldwide basis. Most recently, their 2008 estimate was that this had increased to 3,100 million X-ray examinations, a dramatic increase. And this has consequent effects on the collective effective dose of radiation received worldwide from diagnostic radiology. Remember, collective effective dose is simply the effective dose multiplied by the population receiving that dose. They commented on these figures by pointing out that new higher dose X-ray technology, particularly CT scanning, has been responsible for the rapid growth in the annual number of procedures. What is interesting about this is the implication that new technologies often do not replace old ones, but simply add to the use of radiology. And they also pointed out an interesting consequence of this increase in the use of diagnostic radiology, particularly related to the use of CT scans. If you remember back to Module 3, where we mentioned the annual average dose of radiation that's received just simply by being alive from natural background radiation, you may remember that medical radiology was considered to contribute quite a small proportion of this annual average dose of radiation. Unskier point out that for some countries, for the first time in history, we have a situation where the annual collective and per head doses due to diagnostic radiology have exceeded those from natural background radiation. What about dentistry? Let's try and focus in on very relevant figures. Well, approximately 1/5 of all medical X-ray examinations are performed by dentists when we look at worldwide figures. In some countries, this is a larger proportion. The average frequency of dental X-ray examinations per 1,000 population for healthcare level 1 countries is a figure estimated at 275. Although this reflects an average figure, and if we look at individual countries, we will see a large variation in this figure. The table on the right only includes a few representative countries that show the kind of range in annual frequency of use of diagnostic dental X-ray examinations per 1,000 population. As you will see, Germany has a figure of 581, at the other extreme, Bulgaria has a figure of 41. There's an awful lot of variation. And this does not necessarily reflect disease prevalence or treatment needs. It actually often reflects the relative socio-economic status of a particular country and the amount of money in healthcare. But it doesn't tell us whether, for example, Germany is using X-rays too frequently or whether Bulgaria is using X-rays too infrequently. We don't actually know what is the appropriate use of diagnostic dental X-ray examinations. Let's also just recap on the radiation doses for traditional types of dental radiology, and we remember from previous modules that the traditional doses are very small. We can see the effective doses associated with intraoral, panoramic and cephalometric radiography are quite small. Nonetheless, it's worth remembering that the doses associated with cone beam CT can be substantially higher. The figures shown for cone beam CT doses reflect those presented in the Sedentech CT radiation protection guidelines published in 2009. Of course, the range of dosage presented will continue to change in the months and years ahead as new surveys are performed and new research papers published, but they give us a broad picture of a range of dose which is considerably higher than conventional radiography. If we think about the risk, again recapping on what was done in previous modules, we know that the risk of exposure to X-rays is a small increase in stochastic effects. In other words, cancer. The picture on the right is a cutting from a British newspaper article highlighting that in the opinion of the writer, 700 cancer cases annually in the United Kingdom were caused by medical radiation. We should also, of course, remind ourselves that the risks are higher for younger individuals and that most dental X-ray examinations are carried out in the under 40 years of age group, as highlighted in the UNSCIA report of 2008. Having dealt with that, let's just think about attitudes to using X-rays. If you talk to a wide range of clinicians, be they medical practitioners or dentists, you often notice a wide variation in attitudes to using X-rays. At one extreme, you may get individuals who have an almost routine approach to the use of X-rays. At the other extreme, you may get people who are reluctant to use X-rays. The sort of comments that you might get from the first category of people is, well, it's there, so let's use it. We have an X-ray machine, we should use it. An attitude of being concerned about missing something. It's better not to risk missing something. There's also an opinion sometimes voiced that having a radiograph or a cone beam CT scan will reassure me and the patient. Of course, dentists occasionally will find something unexpected on an X-ray examination, and that finding, particularly if it is a serious finding, may push them into using X-rays more aggressively than they otherwise might have done in the past. Certainly some dentists will say things like, well, once I found an unexpected cyst on an X-ray, so I think I should always take an X-ray of new patients. Finally, and most controversially, the use of X-rays can be a way of making money for a dentist in practice. At the other extreme, as I said, we may get people who have a much more selective use of diagnostic X-rays, in fact, may be averse to using X-rays. They may voice opinions like, X-rays are not safe, so I only use them when I absolutely must. Some recognise that if they use them routinely, most patients get no benefit. And then there are people that concerned that if they do produce an X-ray image, they may miss something, even when they have a radiograph, that they may not notice a pathology when it is present. And then a very everyday problem is that some dentists would recognise that patients really wouldn't want to be paying for unnecessary tests. Let's look back in history a little bit. Here's a picture from an X-ray department in the early part of the 20th century. As we can see here, a patient is having their chest fluoroscopically screened. This is just a photograph, of course, but in reality, this patient would be receiving a radiation dose over a period of many seconds, if not minutes, to observe the motion of their chest and the movement of their heart. In this instance, the impression is that they're being examined, exposed to radiation, to demonstrate the equipment to a group of visitors. Clearly, this sort of thing wouldn't happen today, because the justification for this examination is unlikely to be present if it's only being done to show visitors. Some of the older people looking at this module may recognise this piece of equipment, a fluoroscope used in shoe shops in the middle of the 20th century in order to check the appropriate fit of a pair of shoes. Clearly, this is not a justified use of medical radiation, and of course is no longer performed. Here's some medical examples. It used to be common practice that prior to employment, people would undergo a routine chest X-ray in the absence of any clinical indication. No signs, no symptoms. You would just have to undergo a chest X-ray. This is clearly not justifiable because the majority of individuals in most situations would have no pathology present, and this is no longer performed. Another practice which was particularly common was if an individual underwent a head injury, that routine skull X-rays would be performed. Today, this practice has been replaced by selective use of imaging on the basis of specific features of the trauma and specific signs and symptoms. So, as we see, whether we're talking about non-medical or medical use of radiation, the use indiscriminately without any clear benefit to the individual has been replaced by more careful choice of the use of radiation. Let's consider the basic principles of radiological protection. These are defined by the International Commission on Radiological Protection. These definitions have been established for some years, but most recently reiterated in their 2007 recommendations. The three fundamental principles are justification, optimization, and finally the application of dose limits. We will look at optimization of X-ray use in a later module. We should point out that the application of dose limits is not applicable to patients. There are no dose limits applied to patient exposure. The reason for this is obvious when you think about it. We couldn't have a situation where a patient was prevented, for example, from undergoing a course of radiotherapy because they had reached their annual dose limit. So dose limits apply to the public and to workers with ionizing radiation, but not to patients. In this module, we're dealing with the first fundamental principle, which is justification. So really we need to try and define what that means. Unfortunately, defining it in a few words is quite difficult, but the ICRP defined justification as the process of determining whether a planned activity involving radiation, for example, the use of cone beam CT on dental patients, is overall beneficial. In other words, whether the benefit to the individuals and to society from introducing or continuing the activity outweigh the harm, including a radiation detriment resulting from that activity. As I said, that's rather a complicated statement, and I suppose the simplest way of putting it is that the X-ray examination should do more good than harm. We should also consider the European context. European directives from the European Commission are a very important tool to direct individual member states in defining their own national legislation. In terms of the use of ionizing radiation in relation to medical exposure, we rely on Council Directive 97/43 Euratom. This says very important things about justification. It says that medical exposures shall show a sufficient net benefit, weighing the total potential diagnostic or therapeutic benefits it produces, including the direct health benefits to society, against the individual detriment that the exposure might cause, taking into account efficacy, benefits and risks of available alternative techniques having the same objective, but involving no or less exposure to ionizing radiation. So again, this rather complicated definition is simply trying to put across the concept of weighing up, in the judgment of the clinician, the benefits, the diagnostic benefits in our case, against the health risks associated with the X-ray exposure. But in the second half of that statement, it raises another important point, that we should always take into account the efficacy not only of the technique we're planning to use, but also of alternative techniques that may have the same purpose but involve less radiation, or indeed no radiation. Thinking very quickly, I might suggest, for example, that if we were considering the X-ray examination of a patient to diagnose dental caries, and we were trying to weigh up the difference between using bite-wing radiography and a cone beam CT scan, clearly the bite-wing radiography has better efficacy and uses a lower amount of radiation than does a cone beam CT scan, and therefore that would be the appropriate choice. In a medical context, if the difference might be between using a CT scan or an ultrasound examination, so long as the ultrasound examination was as efficacious at diagnosis as the CT scan, then clearly that should be preferred because it uses no exposure to ionizing radiation. So think a little bit about this definition. It is very useful. Another statement within the Council Directive is that all individual medical exposures shall be justified in advance, taking into account the specific objectives of the exposure and the characteristics of the individual involved. This again is a really important statement. The first bit is that all medical exposures shall be justified in advance. This effectively says that no patient should be exposed to ionizing radiation before they have been examined by a clinician. We should not have routine X-ray examinations, for example, of patients walking into a dental practice. They must first be clinically examined. The Council Directive also quite strictly says that if an exposure cannot be justified, it should be prohibited. Everything we've done so far has been very theoretical in nature. What we want to do now is look at the justification of X-ray use in the real world, particularly in the context of a dental practice. How on earth do you balance risk against benefit? In a medical context, this can often be much easier because a lot of medical X-ray examinations are associated with very serious diseases where we're saving lives or making a significant contribution towards the health of the patient. In dentistry, much of what we do is not really about saving lives, it's about improving, sometimes to a relatively small degree, the quality of life. So the benefits are less easy to quantify. At the same time, the radiation doses associated with dental radiography are pretty low, and therefore the risks are also difficult to quantify. So we end up trying to put into the balance two relatively low weight factors, and this means that justification, while it makes sense in theory, is harder to do in practice. And in the real world, often dentists simply become habituated to taking X-rays in particular clinical situations, copy what their colleagues do, or perform what they were taught many years previously at dental school. Dentistry also is presented with some very specific problems. One unique aspect of dentistry is the concept of self-referral for radiology examinations. In medical practice, it is normal for a referrer, usually a patient's doctor or a specialist inside a hospital, to refer a patient to an X-ray department to undergo a radiological examination. The justification process is then performed by a specialist in radiology in the X-ray department. So there's a separation of the clinician and the person performing the justification process. In dentistry, this is completely different. In almost every case, the dentist will think that they might need an X-ray examination for a patient and also justify that examination. This seems slightly comic in many ways, but it does mean that there is an increased risk of atypical practices developing over a period of time surrounding the justification of X-ray exposures. Only one person deciding on the use of X-rays does run a risk of inappropriate use. Dental practice is also prone specifically to financial pressures. The need to make a piece of equipment pay for itself will, in some cases, extend also to the use of X-ray equipment. There's also the business rivalry and competition between dentists in a particular area. For example, if a dentist in a town buys a cone beam CT scanner and advertises it to their patients, some patients may perceive that practice as being more modern, more go-ahead, and perhaps a more appropriate practice to attend. Other dentists may then feel that they really must buy themselves a cone beam CT scanner in order to compete effectively in the marketplace. The consequences might then be the increased use of cone beam CT simply because of this rivalry amongst dentists. And of course, dentistry, like medicine, is prone to medico-legal concerns about missing problems, missing pathology in patients, and maybe having some kind of cone beam CT facility and using it will reduce medico-legal risk. Incidentally, that is unlikely to be the case. Having looked generally at justification, let's consider some special situations. The European Council Directive says that special attention in justification should be given to those medical exposures where there is no direct benefit for the person undergoing the exposure, and especially for those exposures on medico-legal grounds. In other words, where there is no obvious health benefit to the person undergoing the X-ray examination, we have to be extremely careful about justifying the use of X-rays. Litigation cases are a prime example. Unfortunately, medicine and dentistry are prone to increasing numbers of problems of litigation where patients are suing their dentists, and in these cases patients often undergo X-ray examinations not primarily in order to provide health benefit, but in order to demonstrate particular things to help in their legal case. In these cases, we must be particularly careful about inappropriate use of X-rays. Another medico-legal example is the use of age estimation using X-ray methods, particularly in the context of refugees and asylum seekers. It is established that most X-ray examinations, and in particular dental X-ray examinations, are highly inaccurate in predicting age, and therefore we must be very careful about avoiding inappropriate use of these techniques in order to make important decisions in a medico-legal context. Another special situation is the use of X-rays in research. Most of you looking at this module will not be involved in clinical research, but it is important at least that we mention this, that any medical exposure for medical research must be examined first of all by an ethics committee set up in accordance with national procedures and or by the competent authorities in that particular country. It is completely unacceptable to use X-rays as part of research studies that have not been approved by the appropriate process for that country. The last special situation I want to talk about is screening. Screening is a strategy used in populations to detect disease in individuals without signs or symptoms of that disease. There is only one X-ray screening program that is widely used, and that is mammography. Screening programs must satisfy very demanding requirements before being acceptable. The web address given on this slide is a list of useful criteria for considering a screening program that is used in the United Kingdom. Having said that, there are many dentists, and this is established by research surveys, who perform screening examinations of their patients, most commonly using panoramic radiography. The research evidence indicates that this is inappropriate because most patients who undergo screening X-ray examinations receive no perceptible benefit. So let's summarize. Justification is the process of determining whether the use of X-rays to take a radiograph or to perform a cone beam CT scan is likely to provide benefits to the patient that outweigh the potential harm. We have useful background information on the principles of justification and the practice of justification in ICRP and European Commission documents. We should remember, at least those of us in Europe should remember, that the EC directive requires member states to incorporate the justification process into national legislation. Justification applies to all medical dental X-ray exposures, but we must give special attention to situations where the individual receives no health benefit, and we mentioned research, medical legal exposures, and screening examinations. So where do we go from this point? As I said earlier, the risk-benefit assessment that we need for justification is difficult for dental radiology. In the next module, we will look at how clinical guidelines and referral criteria can make that process much easier. That concludes this module. We must acknowledge the financial support received by the European Atomic Energy Community under the grant agreement for the Sydentex project.